Today we're going to focus on reading an antibiogram and incorporating an antibiogram into your clinical practice when selecting an empiric antibiotic. So first, let's just take a couple of minutes to tell you about what an antibiogram is. So an antibiogram is essentially a periodic snapshot of local susceptibility rates that incorporates bacterial isolates from your region. Usually these incorporate a year's worth of data, and antibiograms are published on an annual basis. In terms of reading an antibiogram, you'll see there's both drugs and organisms. The organisms are arranged in rows across the table, and in the columns you'll see common antibiotics. So simply to find the rate of susceptibility for a particular organism against a certain drug, all you do is you follow the row over, the column down, and where they intersect is the percent of those isolates that are susceptible to that particular drug. Conversely, you subtract that from 100, and that's the resistance rate. So an antibiogram is used in a few different capacities. One is to essentially follow resistance trends over time. Most antibiograms will have the rate of MRSA or the rate of VRE. So it's nice to have a number of years of data to kind of look at. And then also you can compare resistance rates or susceptibility rates across institutions. Probably most notably for you, though, however, in your practice, is to use that antibiogram when selecting empiric antibiotic therapy. So Dr. Javed and I are going to discuss a couple of clinical scenarios that are very common in your practice and essentially show you how you can use an antibiogram in those particular situations.
Well, thank you, Jeff. And we'll start with a very common presentation of urinary tract infection in a young 36-year-old female. Let's say she presents to your office with dysuria and increased frequency. She has had UTIs rarely in the past, but has used ciprofloxacin, for example, in the past. This time, again, she's presenting with similar symptoms. You do urine dipstick, it shows leukocyte esterase, it also is positive for bacteria. Your clinical diagnosis at this time is urinary tract infection, and you want to use an antibiotic. First, for any of the infections you're considering, you should think about what organism would be the most likely. And in this case, the most likely organism causing UTIs is E. coli. And for E. coli, you need to see what susceptibility data is available, which antibiotics you're going to use, and how it's going to impact your treatment. So when you go down in your antibiogram to the row which says E. coli, and you look at the columns for most common antibiotic used, which includes ciprofloxacin, Bactrim, nitrofurantoin, cephalexin, or other cephalosporins that is being used in your antibiogram. In this case, when we focus on this patient and you look at the antibiogram, you see there's a cephalexin susceptibility is 89, ciprofloxacin is 77, nitrofurantoin is 97, and Bactrim is 78% for E. coli. As you can see, that more than 20% E. coli isolates are resistant to Bactrim and ciprofloxacin, whereas about 3% are resistant to nitrofurantoin. In this scenario, it should be noted that other considerations beyond the antibiogram are important when selecting an antibiotic. For instance, nitrofurantoin is a great option for patients with simple cystitis, but with good renal function. But in a patient with poor renal function, or a patient who has pyelonephritis, is not as good of an option. With pyelonephritis, nitrofurantoin does not have good tissue concentration, and with the poor renal function, you would not have enough antibiotic in the urine. Now let's change the situation slightly. Let's change the case slightly to see how patient factors will affect the way we use the antibiogram. In this situation, a 76-year-old female with diabetes and urogenic bladder present with urinary tract infection to your clinic. She has had at least 4 urinary tract infections in the last 1 year with the organisms like Klebsiella oxytoca, E. coli, Proteus mirabilis, and Morganella. The patient is clearly more complex, has other issues along with various urinary tract infections she has had. And looking at the antibiogram, we see that Morganella is not an organism in the antibiogram, or not all bacteria will show up in antibiogram. A minimum number of isolate is required, and usually is about 30. You will see a fair amount of variation in susceptibility in the rest of the organisms, and between the drugs for each organism. And no one drug has an excellent susceptibility rate for all three organisms. A case like this is challenging given the number of different organisms that have been isolated in the past, which will direct our future empiric choices. As a general rule of thumb, a good empiric antibiotic should have susceptibility rate of 80% or greater for a suspected organism. And in this case, ciprofloxacin or Bactrim appear to be better choices for this specific patient. Now I'll hand it over to Jeff to go over a few other interesting scenarios.
Thanks, Wally. Yeah, so let's switch gears a little bit. So our next patient is a common patient that you'll encounter in the clinic. Essentially, this patient is a 56-year-old female who presents with an upper respiratory tract infection. She has purulent sputum. On exam, she's got diminished breath sounds and crackles, and you suspect that she has a community-acquired pneumonia. So to use an antibiogram, again, as Walid had alluded to, you've got to have a firm understanding of the organisms that are most likely to cause that particular disease state. In this particular case, strep pneumoniae is the most common organism, and other organisms like Haemophilus influenza, Moraxella catarrhalis, and atypical pathogens like Legionella are common in this particular case. So to use the antibiogram, again, we're going to want to know the drugs that are typically used in this particular disease state. And we have things like augmentin, which is amoxicillin clivalonic acid, a fluoroquinolone like moxifloxacin or levofloxacin, and then azithromycin and doxycycline. So let's take a look at the antibiogram information that we've provided for you. So we'll look specifically at strep pneumoniae since it's the most common pathogen. So I guess the most striking detail in this antibiogram is the frank resistance that you see to azithromycin. So only 57% of these isolates collected over the past year were sensitive to azithromycin, meaning that 43% were resistant. That's far below the threshold that Walid alluded to before, which is about 80%. Whereas the other options, like levofloxacin, has 98% of the isolates being sensitive. Levofloxacin is going to cover strep pneumoniae in addition to atypical pathogens. That'd be a great choice to use as monotherapy. You can infer augmentin susceptibility from penicillin, and again, 97% of those isolates were sensitive. So augmentin paired with something like azithromycin for atypical coverage would be a very complete regimen. So again, it's important to know that the current IDSI guideline for the treatment of community-acquired pneumonia actually suggests azithromycin as an agent that can be used in people with essentially no comorbid conditions without previous antibiotic therapy. But they do note that if your resistance rates are higher than 25%, to avoid that particular antibiotic. This is a perfect example of where the antibiogram is integrated into a guideline to really dictate your empiric antibiotic therapy. So let's finish with one final case. Again, this is a common scenario that you'll see that involves a young lady who comes in with skin and soft tissue infection. Her particular case, she's described as spider bite, which happens frequently, that's progressed to a pimple. This is on her lower extremity, and there's some areas of cellulitis around that pimple area. So you know that there are a couple different types of cellulitis, one being purulent, the other being a more strep picture where there's no purulent. So in this case, you'd like to cover Staph aureus, including MRSA and MSSA. So common antibiotics for this particular indication, especially for MRSA, would be clindamycin, Bactrim, and doxycycline. So we'll look at our antibiogram and see if your initial suspicion as to which antibiotic you would use would change. So as you see here, I guess again the most striking piece of information that's available to you is the resistance rate again to clindamycin. So of MRSA isolates, only 81% were sensitive, versus a high proportion of those isolates were sensitive to both Bactrim and doxycycline. Now you're aware of some information in the form of a study that you've read saying, yeah, you can use clindamycin or you can use Bactrim. There's really no difference in clinical outcomes. But again, this is another example where you take your antibiogram and you integrate it into literature that's available or guidelines that are recommended. So in this particular situation, you might want to avoid clindamycin as well. So we've taken certain steps within our institution to consider local antibiogram patterns like this. And I'll have Waleed wrap things up.
All right, thank you, Jeff. Just like you said in your last case about the patient with prolonged cellulitis, we actually looking in our antibiogram recently found that for strep, which causes usually non-prolonged cellulitis, our susceptibility data for clindamycin was dropping below 80%, substantially below 80%, and that has caused us to move away from clindamycin use in the non-prolonged cellulitis scenarios. To wrap things up, it's important to remember the antibiogram is a tool to be used when selecting antibiotic therapy empirically. Once the culture is finalized and the susceptibilities are available, that information should be used to guide the treatment. If you have any questions about the antibiogram, the best place to look for is the microbiology lab that you use for your patients, the hospital that you are affiliated with, or the lab that you work together with. Or you can look at their websites. Majority of the microbiology labs display their antibiograms on the websites as well. With this, we'll conclude our discussion. Thank you very much.